So I'd like to welcome you all to a session by Dr. Almudena Alonso, who you already know, who's working in the Hospital Porta del Mar in Cadiz in Spain. And as you know, Almudena spoke to us last time, covering really the approach to lung ultrasound and the use of chronic lung disease, and in particular, how serial ultrasound can actually be beneficial in those circumstances. Today, actually, she's going to talk about two very important topics, in particular, how we might use lung ultrasound to try and diagnose the initial kind of reasons for respiratory distress. And I think it's a very important topic because in our institute, we are looking at starting a quality improvement project to try and see if we can keep mums and babies together. In particular, using lung ultrasound, especially if we think that we might be able to avoid admission for those babies who are not in oxygen, but in particular who are well enough to stay with the mother. So it's a really, really interesting topic. I am going to hand over to Almudena without further ado. The floor is yours.
Thank you, Alok. As you said, this is a very interesting topic, not only to rely on leaving a newborn child with respiratory distress with his or her mother, but also to decide which infants are high in risk of needing admission to NICU if you were in a level 1 or 2 NICU, need to transfer babies with respiratory distress as soon as possible. So you can use lung ultrasound with this aim, so that you can kind of orientate those babies that would need admission to NICU or would need respiratory distress, or those that will be more like low-risk infants that could stay in a low-level NICU with more intermediate care. Sorry, I'm going to change this. So this is the first part of the talk, and the other part we will be talking about how to use lung ultrasound to optimize respiratory support in these infants as well. And just to remember, this is what we would call the normal aerated lung in any age apart from the newborn age. This will be being kind of systematically reviewing the images. You would have the skin, subcutaneous tissue, thoracic muscles, ribs. This would be the pleural line, A lines, and just a few. Here we can see 1 or 2 B lines. But this could not be the issue in infants just being born. So this group of authors from Australia conducted a study in which they described how was the normal aeration in newborn infants, just positioning the ultrasound probe in their axilla. And they found that in a few seconds, they changed it from a completely consolidated lung that you can see here to just in 1 second, it changed to a lung with an alveolar interstitial syndrome. And in this other, you can see how this patient progresses from an intermediate phase in which you can see some, from a consolidated lung, you can see some bronchogram and then the alveolar interstitial syndrome. So these are 10 babies without respiratory distress that after being born, their lungs collapsed and has to be progressively aerated. And how does this aeration happens in our neonates? Well, this same group conducted another study of term babies without respiratory distress that were examined in the first 10 minutes of life, in the next other 10 minutes, 1 hour, 2 hours, 4 hours, and at 24 hours of life. And they also saw how their lung was changing at the level of their axilla using lung ultrasound. And they created these 3 profiles. Number 1 will be an area of the lung with completely full of B lines, and this will be called as the B lines. Number 2 will be an interstitial pattern when there's B lines, but they are separated one from another, and you can see A lines between them. And number 3 will be a completely aerated lung with an A pattern and without just a few B lines isolated one from the other. So just creating this gradation, they divided the infants according to the image that they saw in each side of the lungs into a bilateral type 3, type 1, 3, type 2, bilateral type 2, type 1, type 2, and bilateral type 1. So as you can see, that what we should have found, what they should have found, is a bilateral type 3 in both lungs, and this would only happen in 20% of the infants in the first 20 minutes of life and remain more or less the same during the first hour, which is the moment when we begin to evaluate the baby with respiratory distress. So although these babies are healthy babies without distress, so as you can imagine, we can have many babies with respiratory distress or many babies without any clinical signs that don't have this normal aerated lung type 3 in both lungs. It was just at about 4 hours when the babies, most of the babies, more than 50% of the babies do have this type 3, bilateral type 3 pattern, and just about 80% or more of term infants without respiratory distress had this pattern at 24 hours of life. So when we are evaluating a baby with respiratory distress, we are in this time frame, and you can imagine that the aeration of the lung is quite different from this type bilateral type 3 that we are watching here, that will be the pattern that we could find in, or that we should find in any other ages. So this also has some implications in terms of the type of delivery that the patient had, in terms that those babies that were born by vaginal delivery and cesarean section with labor, they had the clearance of water inside the lung was faster. So you can see that there were significant differences with the babies born by elective cesarean section, that most of them didn't have any clearance of water at all when they were born in the first 20 minutes of life. And it began to resemble the pattern in the lung of the babies born by vaginal delivery and cesarean section with labor at about 2 hours of life, and it was completely equal to those population of infants when they were about 4 hours of life. So as you can see, those babies born by cesarean section without labor have slower clearance of extravascular lung water, as you may see here. So this may have also implications in how we can or we should evaluate these babies when they have respiratory distress after birth. But not just in the first 24 hours is the moment when we should rely and when the infants do have a different lung ultrasound pattern after birth. These are patients born at term as well, without respiratory distress, and they were evaluated at 10 days of life, 1 month, 3 months, and 6 months of life. And you can see the number of patients that do have more than 3 B lines in each field. And you can see that this is right anterior, apical, middle, and basal, left anterior, right lateral, right posterior, left posterior. You can see that at 10 days of life, almost 30% of the infants still have more than 3 B lines, and this is normal. This is normal progression from the completely collapsed lung to the lung that the babies have been healthy term babies without any sign of that respiratory distress. This will be more or less the same at 1 month of life. At 3 months, it's about 50% of the infants still have this pattern, but it's not just until they are 6 months of age that none of them do have this interstitial pattern or more than 3 B lines in each field. just in the interior areas of the lung. They still persist some areas with more than 3 B lines in lateral and posterior areas of the lung, and this will be normal. So this is a schema of how the lung aeration is or should be in term infants with a normal progression, normal transition after birth, in which they should have normal pleural line, thin pleural line with lung sliding, and just a few B lines, mainly in lateral and posterior areas of the lung. However, we should realize that most of the studies performed in this issue didn't analyze the results obtained in posterior areas of the lung, because most of our babies are in supine position when they are examined. The first study that evaluated the use of lung ultrasound to predict the need of respiratory support in after birth was published in 2012 by Professor Raimondi's group in Naples, and they evaluated, as the Australian study that I showed you, these 3 profiles, number 1, number 2, and number 3, and this is description of the main findings that the infants had in interior and lateral fields of the lung. And as you can see, the 14 babies that did have this type 1 profile in both lungs required admission to NICU, and none of the infants that had this type 3 required any kind of respiratory support, neither admission. So in the whole population, you can see that more than 100 infants, those that have this pattern were low risk patients that didn't require not just a few hours to be able to be transferred with their mothers again. However, those infants with type 1 were high-risk infants that would need to be transferred to another hospital in case that that neonatal unit is not able to provide respiratory support, or more observation or more clinical care in these patients here. However, those patients with this type 2 would be mostly didn't require admission, didn't require any type of respiratory support, but just 4 out of 46 required any kind of respiratory support, oxygen, or non-invasive ventilation. As you can see here, this type 1 would have this sensibility of 70, almost 80% of to predict admission to NICU, 100% of specificity, and the positive predictive value will be 100%, and 97% of negative predictive value. However, as we explained, this is just taking into account anterior and lateral fields of the lung and not posterior areas that we have already described, that usually tend to get better or tend to remove the extravascular lung water more slowly. As we have also described, the clearance of extravascular lung water is slower in babies born by cesarean section. So another Italian group tried to get if these results that we've explained before could be also reproduced in this population, and they got 100 infants born by cesarean section, irrespective of the diagnosis, the final respiratory diagnosis, whether it was TTN or respiratory distress syndrome. We are not diagnosing the respiratory disease. We're just deciding the risk that these patients have of needed admission. And they used the same approach. They graded the lungs in grade 1, grade 2, or grade 3. And as you can see here, those infants that required admission to NICU were those that have this bilateral type 1 profile. And those that had this bilateral type 3 were those that didn't require admission at all. So it's more or less the same results. So although we know that cesarean section does imply a slower clearance of extravascular lung water, this is not that important in terms of grading the risk that one patient has to being admitted to NICU for respiratory distress. This is also taking into account that these infants these authors didn't rely on posterior fields as well. This other study published by a Chinese group used a slightly different approach, and they created these low risk and high risk patterns. As you can see, low risk were those that were called grade 3 and grade 1, grade 3 and grade 2 in the other studies, and high risk patterns were the grade 3. This high-risk pattern, when the authors saw this high-risk pattern had this high area under the curve to predict both invasive mechanical ventilation and any kind of respiratory support, and low-risk pattern did have this area under the curve, this very high area under the curve for not needing respiratory support after birth. They also evaluated in numbers, in O ratio, the chance of predicting any kind of respiratory support according to the pattern described in the ultrasound, as you can see here. The pattern, the A pattern or B pattern did have a reduced risk of required respiratory support, but the coalescent B lines pattern or the existence of consolidations increased twice the risk of being admitted to the NICU. They got a gradation of the number of fields that have to be evaluated with these high-risk patterns. And it's important to note that these authors did rely on the posterior fields. So if they had 2 or more high-risk patterns that included posterior fields, so both posterior fields and at least 1 more, had this sensitivity, specificity, positive and negative likelihood ratio of being admitted to NICU for respiratory distress, and more than three or more high-risk patterns in more than 3 fields did have this diagnostic accuracy indexes to predict invasive mechanical ventilation. So it's more or less the same. When you have this grade 3 or coalescent B lines in any areas different to the posterior areas, that baby does have an increased risk of being admitted to NICU. So just to be more practical and less theoretical, I will show you some clinical cases of how you can do it in your units and how easy it is. You don't really have to really pay attention to the clinical diagnosis or respiratory diagnosis that the patient have. But this is a 10 baby born after a cesarean section that require resuscitation at birth for 20 seconds with IPPV. And you can see that this is the anterior, upper anterior, lower anterior, and lateral fields, when you can see this thin pleural line, few B lines separated one from another, and A lines between them. That would be an interstitial pattern or a grade 2 from the radiation that we've seen in the studies that we've shown before. And this is a low risk profile. The baby was completely breathing well. 1 hour afterwards, was able to be transferred with his mother in that moment. Clinical case number 2 would be a late preterm infant born at 2,000 kilos by a cesarean section as well. Didn't require resuscitation at birth, but began respiratory distress in the first minutes of life. And this is the ultrasound performed after 1 hour of life in the left lung. This is the anterior, lateral, and posterior fields. Remember that we said that the clearance of water is lower in the posterior fields of the lung, as you can see here. This is the anterior area when you can see this nice pleural line with thin pleural line with a few B lines in which you can see A lines in between them. A bit more crowded B line, the number of B lines here, and practically less than B lines in posterior areas. However, in the right lung, we see a similar pattern both in anterior, lateral field, but look at this huge consolidation that the baby has in this area. Apart from this sign here, You can see, I don't know, you can, I don't have the images, but this baby was completely asymptomatic 2 hours after birth, 1 hour after this ultrasound, and this consolidation was completely recruited without any kind of respiratory support. And this is why I told you that sometimes evaluating posterior areas can be a bit tricky if you're not able to really understand the implications of each area of the lung. The clinical case number 3 will be a term born with a normal gestation, a normal birth for his gestational age, normal pregnancy, require resuscitation at birth as well, and develop respiratory distress afterwards. This is the first ultrasound performed at birth. This is the anterior, lateral, and posterior fields of the lung, in which you can see an interstitial pattern that we've said could be completely normal for his hours of age. And however, at 2 hours of life, the baby is breathing better, and the lung ultrasound is completely normal aerated. So this baby is, as you can understand, a low risk baby in terms of respiratory disease. At 2 hours of life, baby has no respiratory distress and began enteral feeding and was transferred to with his mother at 6 hours of life. Clinical case number 4 will be a term newborn with low birth according to his gestational age. He was transferred to NICU because of hair lip, and he was born after an elective cesarean section. Develops respiratory distress, but what we saw in the first lung ultrasound is not this interstitial pattern, but you can see this area here without lung sliding, the normal a thin pleural line without lung sliding, an A profile with any kind of A lines. In case that you have doubts about the normal sliding in this baby, you can see here the M mode with this. You can see that this confirms that there's no lung sliding at all. And in posterior areas of the lung, you see the pleural line with lung sliding again. We're not seeing the lung point in this area, and this baby would have was a mild pneumothorax that resolved after 30 minutes of life, in which you can see again the pleural line with lung sliding. You can see B lines and no signs of pneumothorax at all. And the respiratory distress that the baby has was due to this small pneumothorax that resolved in the first minutes of life. He didn't require to be drained, and the baby began enteral feedings in the first hours, and he was discharged at 1 week of life. This is another case of an infant born at term due to a cesarean section as well. And this baby, we are called because the baby begins with respiratory distress when the baby is 3 hours of life. And this is the first ultrasound that we perform in his lungs. And you can see here how different this profile is from the other infants. This is anterior and lateral in both lungs. You see how pleural lines fragmented. This is thick. We see small consolidations, both here and this air as well, this big other one. You can see this B profile all through the lung. That's saying that the baby has completely de-recruited lung after birth, that this baby is the kind of baby that we should not wait to see if the respiratory distress resolves. We should begin as soon as possible with non-invasive ventilation, and this is what we did. And the baby had this his respiratory distress resolved in the first 12 hours of life, and we were able to remove the respiratory support at 18 hours of life. So I hope that after all this, you have been able to understand that using lung ultrasound in first minutes or hours of life can help you organize newborns according to the risk of developing or needing respiratory support after birth. But it can also help you to rule out or rule in some other diagnoses, like, for example, snow pneumothorax or any other kind of Ehrlich syndromes. So this is a small first part of the talk. I don't know, Alok, if we should have first Q&A session here or maybe at the end.
We can do it at the end, Almedina.
Okay. So we can move on to the way that we can use lung ultrasound to optimize respiratory support. And we would describe how can we use it once that the baby has been admitted to your NICU or to your neonatal unit, and the baby has begun on non-invasive ventilation or needed any kind of invasive ventilation to provide surfactant or whatever. How can we use lung ultrasound to decide the risk of developing non-invasive failure or predict extubation failure after being intubated, the weaning of non-invasive ventilation after the initial phase of RDS, or how can we optimize respiratory support, and how can we deal with PDA using lung ultrasound as well. 2014 is the first paper that was published by this group from Naples, in which they also use lung ultrasound to know the value that this has to predict the failure of non-invasive ventilation in infants admitted with respiratory distress. And this is a paper that was published using both term, preterm, and extremely preterm infants up to 29 weeks of gestation. And they also use these 3 profiles, 1, 2, and 3 that we've described before. And once that the baby was at least 1 hour on non-invasive ventilation, you can see that if the baby still has this pattern, this grade 1 pattern of alveolar interstitial syndrome in their lungs, they have this 100%, all the patients with this type 1 profile had 100% chances of being intubated and developing a failure of non-invasive ventilation. And none of the infants with this type 2 and type 3 required intubation at all. So the existence of this bilateral type 1 had this sensitivity, specificity, positive and negative predictive values that increase very much, those that we can have just performing an X-ray. So in this case, lung ultrasound is giving us more information apart from the diagnosis of the patient. We also can stratify the infants according to the risk of failing a type of respiratory support we are providing for in infants. This other paper published in 2016 more or less created the infants with low risk and high risk of predicting ventilatory support, invasive ventilatory support. In those that did have this normal aerated lung or patients with TTN had this low risk of being on invasive mechanical ventilation after a few hours. And those patients with this severe alveolar interstitial pattern or with pneumonia or pneumothorax had this increased risk of requiring invasive mechanical ventilation. In this paper, the authors also divide the infants according to this low risk profile and high risk. And you can see how most of the infants in the high risk profile required invasive mechanical ventilation, 25% yes of them, and only few of them that were in the low risk group did require invasive mechanical ventilation. So in this presentation, you would see that whenever you find this pattern, these cholesterol B lines as the extent of consolidations or whatever, irrespective of the type of respiratory support the baby has, this is not good for our patients. What about extubation failure? Extubation failure is something frequently that we found mainly in preterm infants, is the period of life when the extubation failure is more common. We are talking about 30% of adults on or pediatric patients in critical care units develop extubation failure, and in the neonatal period, it could be increased up to 60% or more. So this is something that we see quite often in any neonatal unit. However, we don't have any test that's been able to predict extubation failure with enough diagnostic accuracy in our population. We also know that if we have different extubation failures attempts in our population, these babies could have worse respiratory outcome with high risk of BPD and mortality. And however, if we decide to wait and not try to extubate of infants, we also have an increased risk of developing BPD and the need of home oxygen. So the aim of this presentation would be, can we use lung ultrasound to reduce extubation failure? Is there any specific sign that we can use to help us deal with it? We are talking about some evidence that we have on the use of lung ultrasound after initial RDS phase or in infants with evolving BPD. What happens when RDS is over? Well, this paper published by a Canadian group analyzed 45 infants born before 38 weeks that required intubation for 4 to 5 days. And they analyzed a lung ultrasound score that you can see here. It's a bit different than the one we use for surfactant administration because they had this score 3 with small consolidations and score 4 with huge consolidation at the level of the pearl line. And they evaluated using both this score and diaphragmatic ultrasound 1 hour before extubation attempt. As you can see here, they got significant differences from those that were successfully extubated at 3 days and those that remained successfully extubated at 7 days, those that didn't. You can see here. And only lung ultrasound score was the variable that was related to extubation failure. You can see that any of the diaphragmatic measurements had any differences in both groups. And they got this cutoff value of 15 points to divide the infants with high or lower risk of being reintubated after the extubation attempt, with this sensitivity and specificity values that you can see here. This other study published by a Chinese group, they got more than 200 infants, preterm infants, with an extubation attempt, and they divided them according to the extubation success or extubation failure group. And they got that using lung ultrasound, also calculating lung ultrasound score, was as accurate as a combined model that used both sex and birth weight, gestational age of the babies after birth, both in the original sample and the sample that they used to validate this model. And this other paper, a bit more simple, but maybe easier to understand, divided the infants according to the type of pattern that they saw before the extubation attempt. In abnormal, they have this coalescent B-line pattern or big consolidations, or normal patterns that did have this A pattern or interstitial syndrome with an increase of B lines that were not that was separated from one to another. As you can see here, babies with normal pattern did have a rate of successful extubation up to 90%. And those with abnormal pattern were half of them were required reintubation and half of them were successfully extubated. So when you see the summarize in this part would be this: if you see this pattern or huge consolidations, the baby is on high risk of developing extubation failure, and maybe you should wait to extubate those babies until the lung ultrasound pattern gets a bit better. This will be an example of how we can do it. This is a preterm infant born at 27 weeks with this birth weight that was born in a peripheral center and required intubation at birth, received surfactant by a selective intubation in the right main bronchus. So he was transferred to a NICU. We had to repositionate the endotracheal tube, and the baby got stable, and at 3 days of life, we are aiming to extubate him with this FIO2, but we perform an ultrasound before the attempt, and this is the left lung. I remember the baby received surfactant only in the right lung, and you can see, sorry, only in the left lung, but in the upper areas, you can see how this lung is a bit more aerated with this less than B-line pattern as well, and lots of consolidations in lateral and posterior areas of the lung. That's indicating that the baby still has an active respiratory distress in this part of the lungs, and a bit better in the right lung, in which you can see this confluent or coalescent B-line pattern in both interior, lateral, and posterior areas of the lung. And this baby would be classified as a higher risk of developing extubation failure. Although we saw these signs, we decided to extubate the baby. It was a few years ago, and the baby had an extubation failure after 12 hours of the attempt. But what happens after the RDS is over, when the babies we are not able to extubate them successfully, and the babies get to be 10 days or 14 days of life, and they are progressing to an evolving BPD. There's no studies published up to date, and I'll show you some data that in which we maybe may think not just in the value of lung ultrasound score, but also the existence of consolidation in the pre-extubation exam. And this is because babies with high risk of extubation failure are those born before 28 weeks or maybe before 26 weeks, in which we know that we usually are able to extubate them at about 1 month of life. As you can see here, this is data from a Spanish cohort published in 2022, in which you can see that in green are those that are on non-invasive ventilation, and blue are those still intubated, and yellow those that didn't require respiratory support at that moment of life. Those babies without moderate severe BPD at 20, and if they were born at 23, 24, 25 weeks of life, they were still intubated until they get to be 1 month. And after that, we usually are able to extubate them, but they still are on high lung ultrasound scores at that moment. If you remember the other talk about BPD, we explained that babies born before 28 weeks do have this persistently high lung ultrasound scores in the first 1 month, when 1 month of age, and after that, this lung ultrasound score begins to decrease. This is a bit faster in infants born at 26 to 27 weeks, but you can also see how lung ultrasound scores are still a bit higher in the first month and decrease afterwards. But this population are able to remain extubated, most of them just since birth. However, this population seems to, usually we are able to extubate them before this lung ultrasound score begins to decrease. So maybe we should look at any other signs, try to get the low risk profile or the babies with high risk of being reintubated after the attempt. So we performed this study that was presented in an European Congress in Barcelona 2022, and we compare in extremely preterm infants born before 30 weeks, those we perform lung ultrasound score and a lung ultrasound exam before an extubation attempt, and we calculated respiratory severity score as a score to measure how sick those babies were in that moment. And you can see that those babies with extubation failure and those that did have similar respiratory severity scores, but they didn't have a similar lung ultrasound score before the extubation attempt. Those that did have an extubation failure did have lower lung ultrasound scores compared to those that failed, but they were not clinically that different, because lung ultrasound scores were about 12 in those that didn't have extubation failure, and about 14 those that did fail the attempt. However, if we take into account the number of consolidations that those babies had, we can see that those babies without respiratory, without extubation failure, did have usually 1 or 0 consolidations. Those with extubation failure got more than 2. And in terms, if we divide the infants with extubation failure according to the number of days when they failed, you can see that those that fail in the first days after the attempt had the higher number of consolidations. So if you find a pattern of high lung ultrasound score with a few consolidations, that baby won't be candidate to have an extubation attempt, probably. Just combining all these variables together, lung ultrasound score, the number of consolidations, gestational age, birth weight, and respiratory severity score, we can calculate a model using logistic regression to predict extubation failure, as you can see here. And if we take into account only clinical variables like gestational age, birth weight, and respiratory severity score, you can see that the area under the curve to predict extubation failure is quite low. But if we add lung ultrasound score and the number of consolidations that the babies have, the area under the curve can be increased to higher than 0.8 with statistically significant differences. This would be an example. This is a preterm infant in which you can see the pre-extubation exam before an extubation attempt. This is a 24-weeker at 14 days of life. And this is just posterior areas of the lung, both the right lung and the left lung. And this is the upper posterior area, lower posterior area, upper posterior and lower posterior. You can see this huge consolidation due to being in a supine position for a prolonged time. In this case, before the extubation attempt, we can try the baby in 1 hour in a prone position, and you can see how the lungs have been improved, how the consolidations have been recruited, and at this moment, the baby is in a best situation to have an extubation attempt. We can also use the lung ultrasound performed after an extubation attempt. We cannot avoid the extubation failure in this situation. It's just that you can try to use it also to stratify the risk of developing extubation failure, but you don't see many differences in terms of lung ultrasound score in those that failed and those that didn't, neither on the number of consolidations that the babies had. So it seems that lung ultrasound performed before an extubation attempt is most useful than do it after the attempt. This could be logical. This is another example, or a 24-weeker born with this birth weight, in which we are performing the first extubation attempt after 14 days of life with this FIU2. And this is the lung ultrasound performed before the extubation attempt, in which you see that the lungs are not clear. You can see this cholesterol B pattern and all through the lungs, even small consolidation here in posterior area of one lung. However, the baby was extubated using non-invasive ventilation, and you can see how lots of consolidations begin to appear, both in anterior, lateral, and this huge consolidation seen here in posterior area in the lung. That's showing us that this baby probably would have an extubation failure. There's some publications, as we've seen before, about the use of diaphragmatic ultrasound or the combination of lung ultrasound and diaphragmatic ultrasound in preterm infants to help in deciding the risk of developing extubation failure. But nowadays, there are no clear results, and there are really big data that says that diaphragm ultrasound can be used to help us deal with this issue. So this is why I'm not going to show you more evidence about this. Once that we have been able to extubate our infants successfully, the babies can be on non-invasive ventilation for a very long time, even weeks or months. So sometimes we also need some help, some tools to decide when's the best moment to reduce or remove the non-invasive ventilation, in which we also don't know. There's no test that can help us deal with this. And this Canadian group also published 2 years ago this study in which they performed lung ultrasound exam, calculating the lung ultrasound score before removing nasal CPAP. And as you can see, the area under the curve is quite high, with almost with a value of almost 1.9. And they got this Could-of-Bailey of 8 points, with this sensitivity, specificity, positive, negative predictive value, and this 4.3 positive likelihood ratio and 0.3 negative likelihood ratio, that makes it a very nice tool, or promising tool, to help us deal when is the best moment to remove non-invasive ventilation in this population. And this Turkish group also a few weeks ago published a similar study. These are not extremely preterm infants. These are preterm infants born at also late preterm infants with non-invasive ventilation. And you can see here that using lung ultrasound, the sensitivity and specificity to predict non-invasive failure is quite high, almost 0.9. And this will be some examples that more or less what you can do in a practical manner. This is 26-weeker. That's a non-invasive ventilation more than 1 month ago. And if you perform lung ultrasound exams week by week, the profile is more or less the same, with this thin pleural line, but lots of B lines, completely coalescent pattern all through the lungs without consolidation. But the baby in this moment probably won't be able to be weaned from non-invasive ventilation. If we decrease the moment where the baby could be able to breathe without respiratory support, is when you begin to see more space between the B lines, when the baby changes the aeration profile from a completely coalescent B profile to a more aerated and interstitial pattern when B lines are separated one from another. So in this case, again, sorry, I'll show a clinical case before. This is a 28-weeker. She's born at 708 grams by an urgent cesarean section due to her low birth weight. And she required resuscitation at birth. She received non-invasive ventilation for 8 days. She didn't require surfactant at birth. But this is how their lungs look like at 8 days of life. This is the left lung, in which this is the anterior, lateral, and posterior areas of the lung. You see the pleural lines a bit fragmented, but you see lots of B lines all through the areas evaluated, some of them with space enough to see A lines. And this is the right lung at the same moment, a bit worse aerated. But at that moment, the neonatologist on charge of the patient decided to progress her to a nasal CPAP. She required a FiO2 30%, but after a few days, she's still in nasal CPAP. She's stable, and the baby had this non-invasive removed. And this is what happens when the baby is without non-invasive ventilation. The baby begins with respiratory distress, and you can see how the lungs are getting collapsed with small consolidations all through the areas evaluated, more B lines. And in that moment, we can diagnose the baby is having failure of non-invasive withdrawal. So the baby, in that moment, the baby needs again to be transferred, not to nasal CPAP, but to non-invasive ventilation again for about 3 more weeks. So the final message would be that if you still see this pattern in a preterm infant, not try to remove non-invasive ventilation until you see until you see a very aerated lung with B lines separated and a few A lines in between them. That baby, after required non-invasive ventilation, required 4 days more with high flow nasal cannula, and finally was able to be discharged home on oxygen. Another infant born at 34 weeks with this birth weight that required a complex course of prenatal corticosteroids. She was born by a cesarean section and didn't require resuscitation at birth, but did develop a high work of breathing that required non-invasive ventilation without improvement, and she was intubated and required surfactant administration. This is the X-ray performed at 3 days of life after the time on invasive mechanical ventilation. And so the baby is still, when we see the baby for the first time, she's still in non-invasive ventilation in the 9th day of life. She has mild respiratory distress with these load gases. And the baby is still on lateral position because the previous neonatologist thought that maybe the atelectasis was the reason that these babies still have this respiratory distress. And this is the ultrasound performed here, in which you can see that in any of the areas evaluated, anterior, upper anterior, lower anterior, lateral, and posterior areas of the left lung, neither in the right lung we can see any atelectasis at all. So we can see that probably the reason for this distress was not the lung. Maybe this baby had an atelectasis that had been completely resolved after the days that this baby was in non-invasive ventilation. So we removed the interface, nasal interface, and we cleared the nose, and we found some plugs in both holes, and the baby developed some mild respiratory distress, but it resolves in the first hours, and the blood gases improved for 24 hours after that. So this is important. When you see a normal aerated lung, you can have enough confidence that this baby will be able to breathe without non-invasive ventilation at all. And some few words about how can we use lung ultrasound to optimize the ventilatory support that the baby have. This is another case. It's this baby born with low birth weight after 34 weeks of gestation, didn't develop respiratory distress after birth, but required a laparotomy at 16 days of life due to a spontaneous intestinal perforation. She was stable after the surgery, but 3 days after that, when we go to see her in one morning, she's high respiratory settings with this FiO2, high peak expiratory pressure. And when we perform lung ultrasound, we found this consolidation here next to the next to the heart, in the right area of the lung. And we aspirate some secretion, place the patient in left lateral decubitus. We perform lung ultrasound, in which the consolidation is getting improved, but not completely resolved. We increase the value of PEEP pressure, replace the position of the endotracheal tube that was too deep, and then we are able to see how the lungs getting completely recruited and how the pleural line is sliding again, and we don't see any consolidation at all. So this is something that something that we should add in our normal clinical exams for our patients. Those patients with respiratory support or with respiratory distress should be evaluated to see if we can improve their respiratory situation using lung ultrasound as well. Another patient, 29 weeker, with 1,000 grams at birth that had a perinatal asphyxia and severe RDS that required 2 doses of surfactant with invasive mechanical ventilation that was extubated at 5 days of life. On 7 days of life, the baby's on non-invasive ventilation. We find these normal gases and we perform lung ultrasound. This is the 7th day of life. And we find this huge consolidation in the posterior area. We can see small area in the upper part of the posterior area and a bigger one here. Baby is stable. We try not to do some he doesn't have respiratory distress, blood glasses are normal, but we check it again the day after. This is at 10 hours a.m. And the blood gases have the blood gases are worse. FiO2 is higher, so we think it's the moment to do something to improve this consolidation, and we change the baby's position to a prone position. And this is the example from 8 hours after, in which you can see how the lungs have been recruited, how the lung has been recruited, and the blood gases have improved. The baby needs FiO2 21% with higher saturation, oxygen saturation as well. So we also use this to decide which is the best position for babies with chronic lung disease or babies that need respiratory support for a long period of time. This is something that has been studied in children and adult patients with RDS, but there's no publication in terms of clinical impact in very low birth weight infants. And we're talking not just in acute respiratory distress syndrome, not in exacerbation, but with more or less stable infants that still require respiratory support after initial phase of RDS. This is, for example, 2 babies born at 24 weeks on invasive mechanical ventilation, in which we are performing lung ultrasound and we find these big consolidations in upper part of their lungs. However, the babies don't have respiratory distress, didn't require increase in respiratory support. Should we try to move the endotracheal tubes? Should we try to change the baby's position? This is something that's not clear, and we do still need more studies about this. There's just one study performed in adult patients after the initial phase of RDS, in which the physicians and nurses used lung ultrasound to decide on the need of nursing or changing position just using lung ultrasound. They were the intervention group, and the other group that just rely on clinical signs like auscultation or the existence of respiratory distress, blood gases, and so on. So the babies in the intubation group had lower time of mechanical ventilation time. They had less episodes of aspiration and less ventilatory associated pneumonia. So maybe in the future, we should also have similar results in our population, but nowadays we should have to wait. And what about PDA and lung ultrasound? Can we use lung ultrasound to monitor the effects of PDA on the lung? Well, there's a few papers. This is a meta-analysis published 2 years ago about combining lung ultrasound and thoracic X-ray to see the extravascular lung water. And you can see how lung ultrasound has higher sensitivity and specificity and negative and positive predictive value compared to both clinical and radiological assessment. So we can use it to see whether if a baby has lung edema. And there's a few publications that have shown higher lung ultrasound scores in very low birth weight infants that did have persistent PDA in the first days of life. This paper by Dr. Trish Woods in Australia compare very low birth weight infants in terms of having a closed or patent PDA after birth in the first day 3 to 4, day 7 and onwards. And you can see how there are significant difference only in the first days of life in those babies that do have this open PDA and those that didn't. This other paper by the group in Naples also shown that patients that did have a PDA that required treatment, that those with complications not related to PDA, the group with light gray bars, you can see how they have this higher lung ultrasound scores compared to those without any significant mobilities, which are the group with dark gray bars. However, we have to rely that the patients in the first days of life, which are born very preterm, do also have another disease that can be difficult to differentiate from lung edema. RDS shows, as you've seen in the previous talk, an increase of B lines that it's more or less the same signs that we see in a patient with lung edema. Sorry? No. And we also know that the extremely preterm infants are those with high risk of RDS and high risk of PDA. So when we are evaluating extremely preterm infants and in the first weeks of life, we know that all of them have increase of lung ultrasound scores because they have an RDS. So how can we differentiate those with a PDA and RDS and those with only PDA? We are not able to do so. Even those, we explained in previous talk, even those that didn't have need of surfactant at birth do have an increase of lung ultrasound scores after that. So in these papers that I've shown you before, those that were studying the effect of PDA on the lungs, they analyzed different populations of preterm infants, as you can see here. The first study analyzed all preterm infants, and the others analyzed infants more premature with RDS. But they also used different grades of different definitions of PDA. Different sizes and different gradients between left heart and right heart. So this is something that it's not completely defined so that we can have a decision of how can PDA be evaluated using lung ultrasound. But what's mostly important is that in any of these studies, the authors explain what was the respiratory situation of the infants. I mean, how was the lungs evolving? Did they have RDS? Didn't they have? Did they have any kind of respiratory support? Were they intubated? Were they not? So maybe the signs that these authors have described are not really due to the existence of a PDA, and maybe they were created by the existence of RDS. And this is some examples that maybe are more practical to understand this concept. This is a 24-weeker at 2 weeks of life. This infant, this is a female infant with PDA. You can see how these lungs look like. They have this thick pleural line, small consolidation, a cholesterol B pattern in all the areas evaluated. And this could resemble a chronic lung disease, an evolving BPD, but this could be also due to the existence of the PDA as well. However, this other patient was a 28-week patient born with after an oligoapneous and hypoplastic lung, which is developing an evolving BPD and doesn't have any PDA at all. As you can see here, the lungs look completely the same to the previous one that we've seen before. And this is not due to the fact that the baby does have lung edema and only due to the existence of an evolving BPD. However, this infant born at 30 weeks, at 2 days of life, does really have a PDA, and this infant still at 2 days of life should begin to improve the respiratory, their lung aeration using lung ultrasound. In this population, lung ultrasound can be more useful to see the effects of a PDA in their lungs, because these patients should have improved lung aeration after the first days of life. In this moment, this baby does have a significant PDA, and at the 3 days of life, when the ductus begins to close, you can see how the lung is improving, how the RDS is also improving again. So this is something that we also studied last year, in which we analyzed infants born before 32 weeks with lung ultrasound and echocardiography at the same time. And we were able to describe that those infants that were born between 28 to 32, the lung ultrasound score correlated well with lung ultrasound score. Those that have a persistent ductus arteriosus with hemodynamic significant values did have higher lung ultrasound scores. But those infants born before 38 weeks, the lung ultrasound score didn't have any correlation at all between any of the PDA measurements, because these infants do have persistently high lung ultrasound scores irrespective of their situation or the PDA. And just a few words to talk about the use of lung ultrasound score after treatment for PDA. This is one series of 5 cases reported by American group, in which they perform PDA closure by catheter closure at 41 days of life. And they combine both echocardiography measurements and lung ultrasound score in anterior and lateral fields. And they described how after the procedure, after the PDA closure, they shown this decrease of left ventricular output, as well as a decrease in lung ultrasound score in the first hour after the procedure and 6 to 12 hours after that. So again, and this summary of the whole talk. When you see this image, when you are trying to know the risk of failing non-invasive approach after birth, or extubation failure, non-invasive remove after being intubated, or trying to decide the risk the baby can have of failing respiratory, any kind of respiratory approach that you are having. When you see this pattern or the existence of consolidations, these babies would have a high risk of not being completely stabilized with any kind of respiratory support that you are giving. So this increases the risk of being admitted, the risk of being intubated, or the risk of having an invasive or non-invasive withdrawal failure. However, this is something that's good for stable, very low birth weight infants in the first month of life, and we cannot use it to decide on a PDA treatment or not. I hope that this was able to more or less help you with your learnings. And this is a picture of my house in the south of Spain. I hope that you enjoyed the talk, and now I'm open to all your questions that you may have.
So feel free, folks, to unmute yourself or pop any questions into the chat. Dr. Ashraf, any questions? So I have one question, Dr. Almedina, and that's really with heart-lung interaction being quite a significant area of development, especially I'd say in the first week of life when the duct is quite significant. There's definitely benefits in being able to do lung ultrasound along with hemodynamic assessment to kind of try and I would say optimize treatment of the PDA. But we now have studies which show that actually treatment in the first week of life, in particular the use of brufen, is associated with very poor outcomes, especially after the study that Samir has done. And that then obviously brings in the importance of serial lung ultrasound in such situations. What's your experience with regards to that? And I mean, how do you manage PDAs in your unit at the moment?
The message would be that we cannot use lung ultrasound to decide on a PDA treatment or not. Because in some algorithms, some people are using this. They see an alveolar interstitial syndrome, that maybe this could be due to the existence of lung edema and so on. But in my opinion, you cannot use lung ultrasound for this purpose, because you are maybe changing, or maybe not, but maybe you are combining, what you are seeing really is the lung edema due to RDS in the first days of life, or due to respiratory insufficiency of prematurity. So I'm not saying that you cannot see lung edema, because you can, but it's very difficult to use lung ultrasound to decide on a treatment
For the
related to
period
PDA.
isolation.
In my unit, what we do is we perform echocardiography, and we see the respiratory situation of the infant. And if we believe that this baby's lungs are not being able to improve due to the PDA, we decide the treatment. But we do not rely on lung ultrasound for this purpose.
That's really helpful, very clear. Anne, feel free to unmute yourself.
Hi, it's
Hello.
less beautiful in Dublin. Thank you for your talk.
Thank you.
I have a question, but I'll tell you the story of the baby I'm thinking of as well. It's really how you could use ultrasound to decide about postnatal corticosteroids, and maybe a repeated course. A little girl I've been watching as I've been doing this course, 500 grammer, born at 25 weeks. Very bad lung ultrasound at the start, loads of consolidations, a couple of doses of surfactant, but wasn't on a ventilator for a long time. So she's had a course of corticosteroids. She's on CPAP, but she still has quite high oxygen requirements even this week. And she doesn't have a PDA anymore. She developed quite a lot of kind of left ventricular hypertrophy on her first course of steroids. So I guess I'm on call. I'm in work this weekend, and I'm thinking about her, and she still has quite a high oxygen requirement. But I did her lung ultrasound Thursday, Friday, and she has the best images I've seen of her whole life. So really interested in your thoughts. I promise I won't make any big clinical decisions based on it, but just I've been watching her this week and thinking about her.
Yes, very nice that you begin to think about that. How old is she now?
She is just over a month. She's 5 weeks now.
Okay, so that's the normal moment where those lungs should begin to improve. So I should wait there, even though she still needs a high respiratory support. Maybe it's due to the fact that she still has low, high pulmonary pressures. Because if you see that the lungs are improving using lung ultrasound, or improving the aeration using lung ultrasound, then maybe the treatment that you should have was not to repeat postnatal corticosteroids. Maybe you should look at the heart itself, as well. As Alok said, we have lots of heart-lung interactions, and maybe if you can use lung ultrasound to see if the problem is for the lungs, or the problem is due to the heart, or maybe both. But at that moment, if you're already seeing hypertrophy in the ventricles in the first course of postnatal corticosteroids, she's in non-invasive ventilation, and the lungs are improving, maybe I should wait and not try to have another course of postnatal corticosteroids.
Good. That's what I was thinking too, but I'll have to hand over to all my colleagues tomorrow. So I'll say we've thought about it. Thank you. I enjoyed your talk.
Thank you.
We've got questions from Alberto. Alberto, you can unmute yourself. Go for it.
Yes. Thank you. Thank you very much, Dr. Almudena. I would like to ask how we combine the data from the transition with the lung ultrasound score to decide the admission of a newborn. That, as you said, we have 1 hour, 2 hours, and more than 50% of the babies take more than 4 hours to improve their lung ultrasound score. So how can we combine that data with all of it said before? That do we have to do serial exams, or we'll decide first clinically and then do an ultrasound?
No, all studies have been performed at about 1 hour of age. So at that time, you can rely on your exam. If you see a completely normal lung, a profile, you can rely on that, and you have to be clear that that respiratory distress is going to improve in the next minutes or hours or so. If you find an alveolar interstitial syndrome, a cholestem B lines profile, or consolidations, you have to begin on non-invasive ventilation in that baby. Well, you can wait, but probably you would need it at the end. And if you find interstitial syndrome, separated B lines in all through the lungs, you don't know. I cannot tell you what to do with that patient. That depends on the respiratory distress that patient has at the moment, blood gases, and so on. So this is why I wanted to understand that that pattern can be normal in patients without respiratory distress. So if you find it in a patient with distress, that doesn't help you what to do with that patient. I don't know if you more or less understood.
Thank you very much. And another question, what consolidations do you consider in your study to preclude extubation? Anterior, lateral, posterior? There were differences between them? Which extension? It was just a number? I was curious about that.
That's a very interesting question. As I told you, there's no studies on that point. We are now, we have a line of investigation with many centers involved in the multi-center trial. I can tell you that the most anterior consolidation is the most dangerous. It is mainly in those patients that are not very premature. Very low birth weight infants do have lots of consolidations quite often. You can try to recruit them, but when you find them in posterior areas of the lung are almost always normal. They just live with that, and there's something that usually that doesn't really get their prognosis worse. But if you find them in interior area of the lung, and if you find big consolidations higher than 1 centimeter, maybe you should try to recruit them. And if you don't, maybe you can try to rule out nosocomial pneumonia, and so on. But anyway, you should try to wait and not try to extubate the baby until that consolidation is improved at least. I don't know if I answered to your question.
Thank you very much.
Almudena, I have a question on that. So naturally, from our perspective, we want to do the scan at about an hour of age. Now the challenge is, I'm just looking at our kind of geographical setup would be almost all those babies would probably be with the mother at that particular point of time in our setup, considering resuscitation, skin to skin care, giving the mother a little bit of time. Now, my one question is, comprehensive scans would involve all regions. We'd almost certainly have to take the baby to our resuscitator. Are you doing comprehensive scans for those babies or just anterolateral scans? Because you wouldn't want to miss in particular, if you did a kind of a problem-oriented scan, I don't have necessarily a history to suggest the baby's going to be at risk of pneumonia or a congenital pneumonia. Would an anterolateral scan suffice just in terms of handling? What's your experience?
Well, I always perform all complete exams in all babies. However, I don't perform exams in babies that are being with their mothers. Maybe it's a different situation in your hospital, but it's something that's really fast, and you can do all fields just in about 1 to 2 minutes. It's very easy. And in that moment, if you may have a concern about a congenital pneumonia, you may find the consolidation both in interior or lateral fields of the lung. So you should try to look for all the fields before trying to get a decision on what to do with that patient.
The entire concept from our perspective is to try and prevent admission to the unit, and we don't want to bring the baby down. So the idea is we'd keep the baby with the mother, provided it doesn't have an oxygen requirement or clinical risk factors that preclude admission. So, the respiratory distress is mild, and classical babies that we often have cesarean section, post-cesarean kind of, we've stopped giving steroids to mothers because of concerns with regards to late steroids, 34 to 38 weeks. And the number of babies that we had kind of admit with respiratory distress has just skyrocketed. So it's kind of something that we're kind of wanting to think of. We want to do it safely because we have very high infection rates as well. So it's kind of work in progress. Any other
Yes,
questions?
doing a great job.
Hi, Dr. Al-Medina, it's Naveen. Thanks for the talk. I'm not sure if there is enough data for this. So it's just, we've been debating about a 23 plus week 550-gram baby, whether we need to give steroids, hydrocortisone, the Premaloc dose or not. But is there any ultrasound, lung ultrasound, which could help with making that kind of decision?
Well, in my opinion, you could try to think of beginning on a steroid course after the first 7 days of life in babies in which you see that lung ultrasound is getting worse. But those babies are not sometimes easy to differentiate in the first 7 days of life, because sometimes they do also have a worsening in their lung ultrasound score after the initial phase of RDS, and that's normal in very low birth weight infants, in the most extremely very low infants. But if you see a thick pleural line in beginning of existence of consolidations, and you have a baby still intubated, maybe you should begin thinking on using steroids in that baby after the initial 7 days of life, but not the initial prophylactic corticosteroids before 7 days of life. Lung ultrasound is not able to help you with that. But that's my personal experience. This has not been proved yet with data, with published studies. Maybe in a few years we could have more information to help you with that.
Thanks, Dr. Al-Medina. There's just one more question about early surfactant use. There are a group of babies, 26, 27 weekers. We might not tube them. We might have to, in an aggressive, vigorous baby, we might just put them on CPAP to start with. Is there lung ultrasound markers which would help us give them like the mist type of surfactant? Is there any studies looking at that?
Sorry, I haven't understood you correctly. You mean babies 26, 27 weeks on non-invasive ventilation to decide?
So early extreme premature babies on non-invasive ventilation. So we have Lisa missed one either of those. So essentially we wait for oxygen to get worse. So the increasing oxygenation or increasing respiratory support or clinical deterioration, that's when we either intubate and give surfactant or Lisa them and put them back on non-invasive. So is that lung ultrasound?
You mean to decide on surfactant administration non-invasively or invasively?
Non-invasively. Lisa type surfactant administration.
All studies performed in using lung ultrasound to decide on surfactant administration are done given the treatment non-invasively.
Okay.
I don't know if that helps your question.
No, it does. Means I clearly have missed 1 or 2 sessions which Dr. Alok has done.
Okay.
I should go back and look at it. Yeah.
Yes, there's many publications in which lung ultrasound, calculating lung ultrasound score at 1 hour of life, more or less. You can really rely on that to decide which infants would benefit of surfactant administration non-invasively.
Thank you. That's brilliant. Thanks.
I have a last question about PDA, because for me it's very interesting, because I know if we have a large PDA with a right-left shunt with still in arterial cerebral artery and dilated chambers, and we have a high lung scores, should it be part of the equation, or we don't consider because we can be with an evolving PDA as well, evolving BPD as well? For me, it seems so reasonable to include this kind of evaluation in the cardiac evaluation as well and cerebral evaluation, that I was very sad with the results of these studies, because it makes so sense. So it's difficult to understand why we can't include it now, because it's very, we can see clinically as well as the X-ray, and then why don't we consider lung ultrasounds in that equation as well?
Your question is, it's so logical, and that's very understandable that you have that you know, that uncertainty, but this is how it is. I mean, lung ultrasound has their limitations, and very low birth weight infants, which are those with high risk of PDA, high risk of BPD, do have a lung ultrasound profile that's not the normal profile in any other ages. And you, with the tools that we have nowadays, we are not able to differentiate what loss of aeration is due to a PDA and what is due to an evolving BPD, because probably both are mixed, and maybe the entity that's making that lung progressing to an evolving BPD is also making a PDA still persistent. I don't know if maybe there's a problem, an illness before that baby's born that creates a pro-inflammatory state that's creating that lung is progressing to a BPD, but also making the ductus arteriosus still open. So it's something that's lung ultrasound doesn't help you to deal with, because if you, it only helps you if you find a normal or almost normal profile. You may say that that patient doesn't have lung edema due to a PDA, but if you see an alveolar interstitial syndrome, you cannot say if that's due to a PDA or an evolving BPD or both. I'm sorry.
Thank you.
Disappointed you.
No, it's not here. Thank you very much.
I'm going to take this opportunity to thank Almudena for an absolutely fantastic session today. Lots of questions. I think lots of food for thought for us as a group, and lots of, I would say, practice still pending from all of you. So the next session that we'll be taking will be the medical legal implications of lung ultrasound, in particular implementing it after training and using guidelines on the unit. That's on Thursday. Thank you everyone for your time this evening. God bless you all, and I wish you a very good evening. Thank you, Almudena.
Thank you all of you for your attention. Thank you a lot for inviting me again. Bye-bye.
Thank you very much.